Good evening, I'm Geraldine Zinn.
And I'm Matthew Ngolovakondoa.
As of March 20th, the Ministry of Health has declared an outbreak of meningococcal disease in Fiji. This life-threatening disease has claimed 13 lives since 2016, 14 of which were recorded this year. To elaborate more on this, we are joined by our guest tonight, Acting National Advisor Communicable Diseases, Dr. Alicia Sahu-Khan, and Dr. Angela Marianos from the World Health Organization. Good evening and welcome to the show. Now, I'd just like to ask, first of all, meningococcal disease. This is not the first time something like this has come up in Fiji. Why is it that it has been declared an outbreak now?
Thank you for that, and thank you for having us on the show. I know that meningococcal disease has been very much in the news and people's minds recently, and for very good reason. I just want to say the Ministry of Health does not declare an outbreak of anything lightly. We do it based on a lot of facts and evidence and decision-making by the experts in the field. And for meningococcal disease, yes, it's a disease that has been here for a long time, but it's one that used to be very rare in Fiji. So before 2016, we had about 1 to 10 cases, confirmed cases every year. So this put our rate of disease at less than 1 per 100,000 population. And if you actually look at the classification of countries based on their prevalence of meningococcal disease, that's low. However, from 2016 onwards, we've noticed a dramatic increase in cases. So before, when we would have 1 to 10 cases a year, in 2016 we had 29 confirmed cases, 2017 we had 48 cases, and so far this year in 2018 we have 18 cases, and there's more that are being investigated and we're just waiting results for. So as you can see, we're only in the 3rd month of the year and we've already exceeded the amount of cases that we would expect for the entire year. So it is definitely an outbreak and definitely something unusual, which is why we came out and declared it to the public, just for everyone to be aware and aware of how they can prevent it.
And how is the disease spread?
So meningococcal disease is caused by a bacteria. It's called Neisseria meningitidis. And it is spread person to person through direct contact with saliva or spit. So it's not as easy to spread to another person as something like influenza or the cold. You actually have to have direct contact with the spit, and usually it's on your face. So any activity that involves having someone's mouth on something else that can touch someone. For example, if you share a drinking glass, and if you're drinking out of glass and you pass it to someone else and they drink out of that glass, or a water bottle. So anything where there can be exchange of saliva between people, there's a chance that the bacteria can spread from person to person. The other very high-risk activity that's even more high-risk than sharing glasses, for example, is kissing on the mouth. So kissing on the mouth is a big one that spreads the bacteria, and it's also related to behavior, because we see most of the cases come up in teenagers and children under the age of 5. And why are those groups? Well, children under the age of 5, for one thing, they're always touching their mouths and things tend to go into their mouths. Little babies, their immune systems are not as strong as adults, so they're more susceptible to the disease. Teenagers and young adults, they're more likely to engage in activities that spread the disease. So kissing on the mouth, going out to nightclubs. In Fiji, we have the tradition of tucking in the nightclub with beer usually. So that activity of actually sharing a jug of beer or whatever alcohol it is, and using the same glass and passing it around a circle, that's where exchange of saliva can happen, and that's where the exchange of the bacteria can happen. However, I do want to emphasize as well that just because someone has the bacteria, it doesn't mean that they'll get the disease, because it's estimated that about 10 to 20% of the population will carry the bacteria at the back of their nose or the back of their mouth at some point in time. And they will be fine. They will never know that they're carrying the bacteria or that they have a chance of spreading it person to person. You only get the disease when when the bacteria goes into your bloodstream. And that is in less than 1% of all people who carry the bacteria. So we are definitely saying to people that to practice basic hygiene measures, don't share drinking implements like glasses or water bottles. When you go out to a club, you have your own glass. You can still taki, but you can use, or everyone can drink from, have one, for example, one jug of alcohol, but everyone just hold their own glass.
But how long does the bacteria survive outside the human body?
It not very long. And Dr. Marianos could probably confirm this for me, but it's not something that lasts a very long time out of the human body.
Of course, this isn't the first time that something like this has come across in the Pacific. Could you tell us more if whether or not this meningococcal disease has had an outbreak in other Pacific islands, or maybe even our neighbouring countries like Australia and New Zealand?
Thank you for that question. In fact, meningococcal disease is very uncommon in the Pacific. The WHO and partners such as the Pacific Community carry out, in collaboration with the Ministries of Health, surveillance for a number of infectious diseases, especially the ones that have got the possibility of causing deaths and a large number of cases, or serious diseases such as meningococcal disease. So we know from the data going back several years that this is a very unusual event for the Pacific Islands. But you're quite right to say that some of our neighbouring countries, such as Australia and New Zealand, have both experienced large outbreaks in the past. In Australia, this has been caused by meningococcal group C, which is the same serogroup of meningococcus that's causing the current outbreak in Fiji. And there were large outbreaks of serogroup B disease in New Zealand in the past. Both of those outbreaks have actually been contained through public health actions that include all of the prevention messaging and awareness raising that Dr. Alicia has already talked about, but also clearance antibiotics, which is antibiotics that are given to close contacts of cases, and then vaccination. And vaccination has proved very, very effective in actually rapidly containing these outbreaks and keeping the levels very low. The other real advantage about some of the vaccines that are being used today, they're called conjugate vaccines. They actually create population immunity. We also call it herd immunity, which basically means that a person who is unvaccinated, possibly because they're too young, such as the babies, are protected from the fact that the population overall has immunity to this disease. And that's why a combination of actions are really important in the management of this disease.
Thank you for that. I'd like to get a little bit more into detail with, of course, the vaccination schedule. But taking a step back, of course, with meningococcal disease, how long does it take before the disease, gets into your system and then you succumb to it? What are the signs and symptoms?
So it has what we call an incubation period of about 7 days. It can be give or take a few days after that. So from the time that the bacteria actually gets into your blood, and that's for the time when you'll actually develop the disease. And so that amount of time. But again, it's very difficult to determine when bacteria has spread from another person to someone else, because as I mentioned, 10% of the population would be carrying the bacteria anyway. So usually it's people who have issues with the immune system. So with immune diseases that affect the immune system, and as Dr. Angela mentioned, young babies whose immune systems have not developed very well, they are the most at risk, and of course the teenagers because of their behaviors.
Thank you. With the symptoms, of course, that are experienced, there may be confusion amongst those who might have it. How are they going to be able to be sure that, yes, I might have it? Going to the doctors most of the time in Fiji, of course, it's not very nice. But you get a slight cold, you get a bit of a headache, and instead of going to the medical professionals, you tend to take home remedies. What would you, advise those who might have it, to look out for? What are the signs and symptoms that they can look out for?
That's a really good question, because as you know, we also have a dengue outbreak going on. It was declared for Lambasa in the first week of January, and then in Nandi and Ba in February, and now it's in Suva for the last few weeks. So with these diseases, sometimes they may have very similar symptoms. But for meningococcal disease, what we want the public to look out for, and this is very much related to the syndromes that they cause. So meningococcal disease, we call it disease because it's actually two syndromes that can come out of it, and sometimes it's a combination of both. So one is meningococcal meningitis, so that's an infection of the lining of the brain and the spinal cord, And the other one is meningococcemia, which is pretty much blood poisoning. So the meningococcal bacteria are in the blood, and they cause symptoms there. So what we want people to look out for, the main symptoms, and the main symptoms that we've seen for cases in Fiji are a high fever, headache, and vomiting. You may feel like vomiting as well. So high fever, headache, nausea, and vomiting. And also just a general feeling of tiredness and weakness. There's also the rash that you can get on your body, which first might start out as pink spots, and then it becomes purple spots, and it gets bigger. But definitely the main thing is that if you have a fever, if you have headache, if you have nausea, vomiting, body pain as well, please do go see your doctor. And we don't want people to be thinking, oh, is this dengue fever, or is it meningococcal disease? For both, really, we are telling people to go to the hospital, go to the health facility, and get checked out by your doctor. So
Thank you for that.
Dr. Angela, did you want to add anything else to that?
Just to say that unfortunately this disease can be more difficult to diagnose in young babies. So because babies can't complain of headaches and they can't tell you if they've got a stiff neck, sometimes the presentation is somewhat different. The baby can become very drowsy, it can become floppy, so it loses muscle tone, and can also actually stop feeding. So it's very important for parents to recognise a change in behaviour of their babies, or their children, or themselves actually.
That's really true. With babies, it's really hard to tell, and with babies in particular, the death rate is quite high. And the thing about this disease is that it can progress from a person being completely well, or a child being completely well, and then within 24 hours, the child has died. That is how quickly it can happen. And so with children, when you don't have specific symptoms for babies, it's up to the parent really to recognize a change in behavior in that baby. I was talking to a mother the other day, and she said, I just knew something was wrong. My baby was not acting like they normally do. That is what we want you to know as a parent, especially young babies. You need to be aware of that.
Thank you for that, Dr. Sahar Khan, and also Dr. Mariano. So we'll get more into that after this break. Welcome back to the show.
So, Dr. Angela, when you spoke about the disease, you described it as like type C. Are there different types of subtypes?
Yes, there are. So there are 13 different serogroups of meningococcal bacteria, but only 6 of those can cause disease, and that's serogroups A, B, C, W135, X and Y. And so what we're seeing in Fiji at the moment is serogroup C.
That's of course similar to the one, was it the same one that was in Australia?
It's a complex disease, so when we say same, it's the same group, but it may not be exactly the same type. And that's where some of the more advanced laboratory techniques are really important, especially DNA fingerprinting, which we call full genome sequencing, that actually identifies the specific genetic information that can tell you whether or not it's exactly the same strain or whether it's slightly different, even though it may be in the same group.
Given that there are all these different strains of meningococcal disease, how do you diagnose that someone has meningococcal disease? Is it just with the symptoms? Or
well, you start off with the symptoms. So first of all, the clinical presentation can be, as Dr. Alicia described it, quite non-specific, unfortunately, initially, but as the disease progresses, you either develop meningitis or the more severe form, which is the blood poisoning type, which we call meningococcemia. So that person will be investigated with a variety of different tests to identify the organism, and that can be either in the blood or in the CSF, which is the fluid that lines the brain and the spinal cord. And that could be either by culturing the organism or other types of laboratory tests that can tell you precisely which serogroup is causing the disease, once you know that it's the meningococcal bacteria. And then, as I mentioned, there's even more sophisticated tests after that that look at the genetic material and also at whether or not the antibiotics currently in use are able to actually combat that disease. So all of these things are done as some of them as a routine and some of them as a more advanced form of characterisation, but to really get a good understanding of exactly what organism we're dealing with, whether the antibiotics in use are effective against the current strain that's circulating in the community, and then what type of vaccine would be appropriate.
Speaking of vaccine, sorry, would you like to add something?
Yeah,
to that?
I would just like to add in terms of the serogroups and for the individual patient. So if someone gets sick in Fiji with meningococcal disease, they're admitted to hospital, they're treated. Actually, the serogroup that it is does not make as much difference to that person's treatment at that time, especially right now, because we know what serotype is causing this outbreak, which is meningococcal C. We know the antibiotic susceptibility, so we know how to treat that patient. So once that person is suspected as a case, they are treated straight away. That's because early treatment is so important. So they're given the appropriate antibiotics straight away. Their samples are taken, so their blood samples, the fluid from their spinal cord is taken, and that's tested. And this testing is available in all divisional hospitals. This is the culture. So with that testing, then that confirms that yes, they do have meningococcal disease. The next step of testing is one that comes actually to the Center for Communicable Disease Control, where we can do a bit of batching and then sending it off. So we do one test there, and then we send it off to Australia to our reference, the WHO reference lab for serotyping. But the bit that actually makes a difference to that particular patient has already happened in the divisional hospital, and the patient is being treated according to what they've found there. Even before that, once we have a suspected case, the patient is treated straight away. So knowing the different serotypes is very useful for us on a program level, because then we know what vaccine to choose. We also know, that these antibiotics are working against it, so we can recommend these antibiotics as the first-line treatment for cases. But for individual patient level, definitely we already have a lot of the testing that's necessary for that patient, and the treatment, of course, is already there in the hospitals.
Speaking of treatment, it's not just, of course, the vaccines. There's antibiotics, as you've mentioned, and of course other stuff that would come into play. With the vaccines, though, what is the vaccine schedule like? Is it a one-off shot that you get, and then you get on antibiotics, or are there multiple, treatments that need to be, taken?
The antibiotics are the first line, and as Dr. Alicia said, what we're really trying to promote is an awareness that as soon as someone feels unwell, they really need to see a medical practitioner for an evaluation. And then if they're diagnosed with suspected meningococcal disease, they're given immediate antibiotics. And that is being done at health centre level even before they arrive in hospital. Meningococcal disease is both a medical and public health emergency. So it's important for an individual patient to get treatment with antibiotics as soon as possible. And from a public health perspective, it's important to have this additional laboratory information to make decisions about the vaccine. The vaccine schedule and the vaccine that will be used depends on a number of factors, including the serogroup. That's one of the most important things to consider, but also the age group. So depending on the age, it may be a single dose, and it depends on the formulation of the vaccine as well.
And are these vaccines accessible for mothers or young kids, in terms of, would they have to pay, or can the Ministry of Health provide them?
Before I go into it, so I just want to talk just very briefly about what are the steps the Ministry of Health is taking right now. So we have a meningococcal task force that was set up specifically for this outbreak, and we have identified there's 4 key areas that we need to address in terms of controlling the outbreak. So the first one is early detection. So early detection involves, first of all, making the public aware of the disease, of the signs and symptoms, and to come really early to a health facility as soon as you recognize it in yourself or your children. So that's public awareness. The other part of early detection, of course, is making sure that our clinicians are very aware. So while all of our doctors go through training in medical school and know how to recognize this disease, because it is such a rare disease, we need to make them more aware. So go out and do additional training with them. So just raising the awareness level and making sure that they have the tools and the skills to be able to diagnose the cases early and refer and treat straight away. The other component, of course, is the early treatment that I just mentioned. So that's making sure that the antibiotics are available to treat this disease. As you know, as we've mentioned, antibiotic sensitivity is very important, that we need to know that the antibiotics we're using are effective and they're not, that this strain is not resistant. So that is very important, and so that also clinicians know that they can refer straight away to a divisional hospital, which is another thing we are pushing for. The other thing is the public health response, and that's where Dr. Angela was mentioning that not only is it a medical emergency, it's a public health emergency. Because once a case is identified, the first thing that one of the first things that happens in terms of notification is the public health team is notified. So every division in Fiji has an outbreak response team, and this is not just for this outbreak. We've had that for a long time. So that team is notified, and they will actually go to the patient's household and investigate. So see who is in the house, who lives with the patient, and then they'll decide based on that who is a high-risk contact. And depending on their investigation, they will decide either to give education material to the contacts and say, okay, look, if you get these symptoms, please go straight to a health facility. Or if the person is identified as a high-risk contact, they will give antibiotics, we call prophylactically, just to clear that bacteria from in their nose and their mouth, just to prevent the further spread of that bacteria in the community. The last one, of course, is prevention. And prevention is very important, so this is what we're emphasizing to the public, is about emphasizing good hygiene practices that I've just already talked about. And of course, that's where the vaccination comes in.
Thank you for that. I'd like to get a little bit more into detail, of course, with the antibiotics, but we'll get more into detail with that after this break. Welcome back. Dr. Sahukhan, earlier on you'd mentioned about antibiotics being a form of treatment. Now I'd like to get a little bit more into detail with that. With antibiotics, if they're prescribed by the doctors, of course, either by our national healthcare facilitators or doctors, or maybe by private practitioners, these antibiotics, are they readily available at the dispensaries and also at the pharmacies?
Okay, so I think first of all I need to make clear that for someone who is suspected to have meningococcal disease, once they come to a health facility and seen by a doctor, that doctor will not send you away with a prescription. You will be treated in that health facility. And the antibiotic that's given is not something where you get out over the counter. It's usually injectable, given intramuscularly or through an IV cannula. But it is definitely not something that you'll be sent away with a prescription to go and buy, and then you wait and then come back. Not like that at all. Every case will be treated as an emergency, and in terms of the antibiotics, the Ministry of Health has the antibiotics in stock. An important thing to note about this particular type of meningococcal disease, it is known to be resistant, has some resistance to some of the previous antibiotics that we used in the past. So the Ministry of Health is making a really strong effort to make sure that this antibiotic is available. And it is available, but we are currently ordering more stock to replenish current supplies.
Given that this isn't the first time that meningococcal disease has hit Fiji, this has been prevalent since 2016. Small numbers, but numbers nonetheless, of course, with the death rate being what it is, 4 in this year itself, 13 in the past couple of years, from 2016 up till now. Looking at the percentage of, or mortality rate rather, of meningococcal disease compared to dengue, what is it and why is it more significant?
So, firstly, worldwide, the death rate is expected to be up to 50% if a person is not treated. If you get the appropriate treatment, even in big developed countries like Australia, for example, the death rate is still between 8 to 15%. In Fiji, last year in 2017, our death rate was at 14.4%. If you compare this to dengue fever in Fiji, it's something that everyone is very used to it. However, the death rate from dengue fever in Fiji is between 0.4 to 0.6%. It's always below 1% in Fiji, even during outbreaks. So if you compare that 0.4% or 0.6% to 14%. That is huge. So just if you're not comfortable with percentages, so 14.5%, that's between 1 and 2 people in every 10 people who get it will pass away, or that with our current rate.
That is quite alarming. With that being said, with the number of cases that have come across in the past couple of years, the death rate, of course, has been 13 so far, but there have been cases where people have been treated, am I correct?
Of course. I mean, and that's the whole approach that's being taken, that early detection, early recognition. First it starts with the person presenting to a health facility, being aware of the symptoms and signs, knowing what to look out for, and as we said previously with parents, recognising any changes in the behaviour of their infants, because babies are not in a position, unfortunately, to complain about feeling unwell. Early recognition, person presents to a health facility, the healthcare workers are primed now. There's been a lot of attention given to enhancing their awareness of this disease, in making sure that they're fully across the Ministry's strategic plan and treatment and public health guidelines, so that every healthcare worker knows what to do. Fiji, since Tropical Cyclone Winston, has actually had 36 surveillance sites across the country that collects information on diseases and reports anything that is unusual or unexpected, including suspected meningococcal disease. So there's a lot of awareness and a really strong network of healthcare workers who are looking out for this disease and are reporting this disease centrally.
With the Ministry of Health stating that, you know, if there's an outbreak, how, from a scale of 1 to 10, how real is this turning into an epidemic? Could it become an epidemic?
If I could rephrase that, what Matthew, probably you might mean to say is, with it being an outbreak, if it's not taken into account, people are not careful about it, would it take a month or 2 before it breaks out into an epidemic, or could it take longer?
I mean, the possibility of it.
I think we are thinking that they're two different things. We are using the term outbreak interchangeably with epidemic.
I see.
There's the way we use it. In other settings it may be used differently, but how we're using it here is outbreak means epidemic.
Okay.
But there is, of course, an urgency, and you know, for everyone to be aware and be on you know, the preventative side to make sure that they don't catch it. Of course, like you mentioned, with coughing, spitting, sharing of utensils, we living in a communal society, of course, being in close contact with everyone, not just, you know, at work, and of course kissing and touching. We share public rides with on the buses and all, so we do need to be a bit more careful with that. Just going back quickly to Dr. Marianos, with the number of survivors, if you've had meningococcal, or mense if I may call it, before, and you've gotten treatment, are you susceptible to it again?
Yes, you are. Unfortunately, this is one of those diseases where we don't acquire long-term immunity. And as I said, there are multiple serogroups and multiple strains. So there is a possibility of getting infected twice, even within the same serogroup, if it was a completely different strain within that serogroup. But definitely there is a possibility of getting infected across serogroups. Having said that, it would be very, very unusual. Fortunately, people don't tend to get infected twice. That is not our concern. Our concern really is about making sure that people are recognised early, attend a health facility early, are given these antibiotics as quickly as possible, because the antibiotics are life-saving. The vaccine is all about prevention. The vaccine doesn't treat the disease, doesn't cure the disease. It's the antibiotics and the good clinical management, including intravenous fluids and other supportive care, that actually saves the lives. So I think it's really important that we focus on what's important now, rather than hypothetical situations about whether or not someone can get reinfected. The message that we want to get across today is what people should look out for, what they should do, and make sure that they actually attend a health facility very quickly if they suspect that they might have meningococcal disease.
Especially just to illustrate how quickly this disease moves. Most deaths happen within the first 24, 48 hours of onset of symptoms. What that means is that you can be well at 8 a.m. on a Monday, and then before 8 a.m. the next day, the person has actually passed away. So that's how virulent it is, and that is why we are so strong on telling people you need to be very aware that if you feel sick, if you notice that your child is not well or just not behaving well, like they usually do, especially small babies, you need to go to a health facility. And as Dr. Marianos mentioned, our medical staff right now are very, very, very clued on to this outbreak and are very much alert and aware of it, and you will be assessed at a health facility.
Thank you for that, doctors. We'll be back with more after the break. Welcome back.
Now, Dr. Khan, earlier on in the week, FBC reported that, FBC News rather reported that you were creating a task force. Who exactly makes up this task force?
Thank you. So this task force has been meeting for 2 weeks now.
Mm-hmm.
And the task force is made up of our clinicians from the divisional hospitals, so from the specific departments of pediatrics and internal medicine and the intensive care unit. So these are our very senior physicians, as well as key public health personnel within Ministry of Health. So there's myself as the Acting National Advisor for Communicable Disease. There's the National Advisor for Family Health, who usually looks after vaccination, for example.
Yeah.
Our Deputy Secretary, both our Deputy Secretaries are in there, as well as Fiji National University's College of Medicine, Nursing and Health Sciences, who have been with us right from the beginning in putting together all the information about this outbreak, and they've been really, really helpful in that. And then, of course, we have our development partners, so WHO, of course, Dr. Marianos is on that task force. We have SPC. So it's a task force that is made up of a really great cross-section of expertise, right from public health. So we have health inspectors there as well. We have the Fiji Pharmaceutical and Biomedical Services in there. So everybody who really needs to be involved in making decisions and planning for the control of this outbreak is on that task force.
And are you planning to work with any groups on the grassroots levels?
Well, once for the task force, we have that's who's in it. We also have teleconferencing in of the divisional teams,
yeah.
So the outbreak response team. So they do join the meetings as well by teleconference. We also consider that we need to think about the GPs, so the private GPs, who sometimes are not as involved in a lot of the decision making with the Ministry of Health.
Yeah.
So we have had the GPs in on one of those meetings, and they will be very involved in the rollout of our guidelines and the training, so that we don't only target Ministry of Health staff, also GPs, because we recognize that they're an important part of the health system as well.
With the number of cases, of course, that were recorded this year, where was it more prevalent? And, these task forces, how far off do they go in? Do they go right into the, rural areas to go liaise with, say, stakeholders over there, maybe schools or relevant authorities over there to, disperse more information, of course?
So this task force is being formed at the national level. So it's based here in Suva. And what the job of the task force is pretty much planning and planning the control of the outbreak. So the decisions are made at that level, including a lot of policy decisions and putting together the guidelines and making sure that all of the logistics are in place and drugs are available. However, the actual response to cases and the treatment of cases happens in our divisions. We have a decentralized health system where we have 4 divisions, so Western, Northern, Central, and Eastern, and each of them are headed by the divisional medical officer. And as I mentioned before, they all have their own outbreak response teams. So those are the people who actually go down to the grassroots levels and work in the field and work at the community level.
I know you're conducting refresher trainings for everyone. Does this include everyone across the board, everyone in those different divisions? Are they well trained again, or rather the refresher training? Are they well equipped again to handle these cases?
So the training will be conducted in all of the divisions,
yeah.
And will include, it's what we call a training of trainers. So
okay.
It's not feasible for us to go out and train every single clinician out there. What we do is, because we have a decentralized system within Ministry of Health, we can go in we pull out one clinician from each subdivision and train them very well. They have all of the materials, the training materials as well. And then when they go back to that subdivision, they train the medical officers and nursing practitioners that are there and report back to us on their training. It will be the same for the GPs. So we will have to arrange with the GPs about who will be the people responsible for training GPs in that sector.
Of course, that's with the training of the trainers, with the medical practitioners who are well equipped, of course, to deal with Men-C. But I was wondering about awareness, public awareness. Of course, not everyone is always glued to the TV or the radio. Most of the children nowadays, they tend to hang out within themselves. And this information, how would it be filtered down to them? Is the Ministry of Health or WHO trying to liaise with schools or the Ministry of Education in some way or the other to sort of disperse information, being, of course, that the target group would be them? They're more susceptible to meningococcal disease.
Yep. So understanding that very well, and of course the popularity of social media as well. We recognize that right in the beginning. So from day one, when we announced the outbreak, we sent out a press release to all news organizations detailing everything about the outbreak and what people need to know. So that went out. We also posted up on our Facebook page, the Ministry of Health webpage, the My Health section of the Ministry of Health webpage. So all of this information, all the communication information about prevention and recognizing early symptoms are up on those pages. And I just checked yesterday, and it's been shared thousands of times already. So we recognize that we need to look at those mediums as well. Other than that, looking at the networks that exist, so school networks, working with the Ministry of Education. I know that at the high levels of government there is communication between Ministry of Education, the permanent secretaries, but also at the grassroots level. Our subdivisional medical officers are in contact with schools, in particular boarding schools, are at risk at higher risk, because the high-risk contacts are those who live in the same household, right? So if you live with someone who has meningococcal disease, you have a higher risk of getting it. So in a boarding school, everyone in a dorm, for example, will be counted as a household contact. So that's why boarding schools are more at risk. They are in close proximity to each other. They're more likely to spread the saliva and spit around. And so we are in contact with boarding schools through the Ministry of Education, of course, to try and ensure that we're preventing spread of this disease.
Of course, like you said, with the boarding schools, children, of course, living in close quarters, some of these boarding schools are a little bit further away from a near health facility. If there were to be if there were to be some sort of an outbreak, if one child were to contract it and then you have about 5 or 6 children living in one room, are they all susceptible to that? Would they all be taken in? Of course, would it be spreadable? I mean, living in a house, of course, there would only be a maximum of, say, about 6 or 7 people, but then you have a boarding school, children use the same towels, cups and, showers and everything. If there's any sort of, my mistake, the strain of the bacteria that could be transmitted to them, is there any way that you could possibly go up or send someone to those rural areas or those boarding schools?
So the public health response, so I talked to you about those 4 different components of our response to this outbreak. So the public health response is very similar, whether the case is coming from a household or it's coming from a boarding school. So the outbreak response team will be deployed to that place. They will do the investigations, assess who is a high-risk contact, and then take the appropriate action, whether it be education, so informing the context, so the students within the school, the teachers to be on the lookout for signs and symptoms, or it will, and often the case in boarding schools is giving antibiotics to clear the bacteria from other students who may be carrying it at the time, that particular bacteria that's causing the outbreak. So it's very similar, and it's a very structured response that we have, and it's very similar across households and boarding schools. The difference in boarding schools, of course, is that we have a lot more contacts within there. So there's a bit of a special situation there. But it's very much following the same sort of process.
Thank you for that.
If you want to add something.
Yeah, and just to say that everything that Dr. Sahu Khan has described is part of international best practice. So these guidelines that are being followed here are based on guidelines that are being used in most countries. And certainly a lot of the information currently in the Fiji case management, the sort of patient management and public health guidelines, are derived from similar guidelines in Australia and New Zealand, the US CDC, the Centres for Disease Control and Prevention, and of course based on WHO's international guidance in this area. So, you know, it's evidence-based. It's a very sound foundation for the response.
Thank you for that. Doctors, we'll be talking more about, of course, good hygiene practices, but we'll be back with that more after this break. Welcome back. Now, to wrap things up on the show, of course, with meningococcal disease being labeled as an outbreak as it is, the one thing that we can do is, of course, prevention. And the steps are very, very simple. Tell us more, please. And, of course, if we were to be a little bit more mindful, how could we stop the spread if we do happen to know someone who has it?
Okay, so prevention is very important. It's something that the public can actually do to help control the spread of the disease and help your loved ones not get it. So again, so the way that the bacteria is transmitted is from person to person through contact with spit or saliva. So it's not as easily transmitted as things like the flu or the common cold. It's not airborne. However, if you're engaging in any activity that involves coming into contact with someone else's mouth, so kissing on the mouth, and this usually it's with intimate partners, so kissing on the mouth can spread the bacteria. There's also a risk that if you use the same eating utensils or drinking implements like glasses or cups or bottles, water bottles, you could also be exchanging saliva and spreading the bacteria that way. In Fiji, of course, we have our unique traditions. For example, with Yangona, traditionally we have a big bowl of Yangona, and then there's a bilo that gets passed around. Well, in those cases, we would suggest bringing your own bilo, for example, everyone having their own bilo. The same for the younger population who may be going out to the nightclubs and having alcohol, sharing alcohol from one jug, and using the same cup. You can still share from the same jug, but just have your own glasses.
Of course, with proper hygiene, a little bit of etiquette would come into play. Yep. Fiji being Fiji, not everyone drives around in a car. We all sit in the buses, we all walk around. And some of us do happen to have bad habits, the coughing and the spitting, and of course just not being careful about covering your mouth. Another thing, of course, would be washing your hands. Am I correct?
Absolutely. So there are two main types of personal sort of risk reduction, if you like, decreasing the likelihood that you're going to actually contaminate your hands, your face, and then potentially touch someone else and pass it on. As Dr. Sahu Khan said, intimate partner kissing is one of the important ways, but that's more difficult to actually prevent, obviously. But things that we can do on a day-to-day basis that actually prevent not only meningococcal disease, but many other infectious diseases is a respiratory hygiene and hand washing. And I'll start with hand washing because that's one of the most important things that we can do. So regularly washing our hands with soap or water, or if they're not visibly soiled, using hand sanitizers is just good practice. And this is always something that we recommend to also prevent gastrointestinal diseases. So, you know, always washing hands after doing things which potentially contaminate the hands and then can contaminate surfaces, can contaminate other people, can contaminate our loved ones actually. And the other one is respiratory hygiene, and that's making sure that when we cough or sneeze, we actually contain the droplets that will be expelled when we cough and sneeze, and that's by doing things like using tissues that are safely disposed, definitely not spitting. If you're going to use a handkerchief, washing that on a regular basis with, you know, hot water and soap. And then it's preferable, rather than actually covering the mouth with the hand, using either your sleeve or your elbow. In fact, that means that you're protecting your hands, and again, there's less likelihood of touching surfaces or contaminating other people through that touching motion with saliva.
A little bit of common sense and a lot of good hygiene practices. Thank you very much, both doctors, for coming on to the show. To wrap up our show for tonight, we hope that every Fijian will take the initiative to practice good hygiene and take preventative measures so we can cull this outbreak. If you think you or someone you know may have symptoms of meningococcal disease, please visit your nearest healthcare facility. And from the team, Matthew and myself, have a wonderful evening.